everything set up.
Build the list.
Sounds good. Tyree, I think I'll use the laptop because all the videos are playing on my laptop, but some are not playing from this computer. So let's just hook this up. Hey, Marvin. Yeah. So how do I play? Oops.
What trying to do?
Can I play it in a big format here?
So they got it for me. Yes, sir.
Hello, everyone, and welcome to our grand rounds from the DeBakey Heart and Vascular Center. Today we have an amazing topic with an amazing investigator, Dr. Sachin Goel. And Sachin has been an amazing force here at Houston Methodist in the structural field and any interventional field. His medical school was in Mumbai in India. Went through a stint through England and did his internship there at the University of Cambridge and Oxford. But his eyesight was further west, so he came to Cleveland Clinic, and this is where he repeated his internship in internal medicine. Did cardiology at Cleveland Clinic. 2 years of interventional work and structural work with Dr. Kapadia, and Samir Kapadia would say he's among his best trainees. And our eyes were on him, so we were able to recruit him, and actually we were fortunate to recruit him because he really has built an amazing program here along with Dr. Kleiman and all of our surgeons. He is Associate Professor of Cardiology. He's the director of our interventional and structural program here at Houston Methodist. And his focus has been really on the outcomes of patients with all these new methodologies that we bring to the catheterization laboratory to enhance patient care and enhance outcome. So he has been in every trial that you can think of, and truly has built over the past 3 years an amazing research group with very productive postdocs. He's at every meeting talking about the registries that we built here in addition to the national involvement in structural heart disease. So it gives me great pleasure to introduce him today. And he's going to talk about something that was forgotten and no longer forgotten, the tricuspid valve. Sachin.
Thank you very much, Dr. Zogby, for the kind introduction and for the opportunity to speak. So we're going to talk about the tricuspid valve from the forgotten to the forefront of transcatheter therapies. Here are my disclosures. So, I'll just share a brief outline. We'll talk a little bit about the anatomy of the tricuspid valve and how it pertains to transcatheter interventions, the burden and impact of this disease, and of course the focus is the transcatheter therapies. And we'll focus on tricuspid edge-to-edge repair, transcatheter tricuspid valve replacement, share some case examples, and then focus on some of the unanswered questions in this field. So this is a typical patient that presents with severe tricuspid regurgitation, who complains of edema. They could have ascites, decreased appetite, fatigue, reduced exercise tolerance, and shortness of breath. So this is a typical example of a patient that is seen in our clinics and hospitals when we are consulted for severe tricuspid regurgitation. So we'll talk a little bit about the anatomy. The tricuspid regurgitation, for the most part, that we see in clinical practice is functional tricuspid regurgitation. This is a result of left-sided heart failure, left-sided disease, including left-sided heart valve disease, pulmonary hypertension, that eventually leads to a final common pathway resulting in right ventricular dilatation, tricuspid annular dilatation, and non-coaptation of these leaflets. The dilation of the annulus occurs primarily in the anteroposterior direction, and the saddle-shaped annulus becomes flatter and more circular, resulting in non-coaptation and tricuspid regurgitation. So this is the main pathophysiology behind functional tricuspid regurgitation. What are some of the anatomical challenges with transcatheter tricuspid interventions in contrast with TAVR and mitral interventions that have grown tremendously over the last decade? Well, the annulus shape is a non-saddle shaped annulus. There's lack of calcium. Most importantly, there's no calcium in this valve in contrast to the aortic valve for anchoring of a replacement device. The leaflets are thin, much thinner than the mitral valve, with tethered cords, which has implications for tricuspid edge-to-edge repair. There's severe annular dilatation, which has implications for valve sizing in cases of tricuspid replacement. Several patients have, a large proportion of patients have leads, pacemaker leads, defibrillator leads, and this is an issue. We'll discuss this. There's proximity to the coronary sinus and the right coronary artery. And of course, proximity to the conduction system, which can result in conduction disturbances. And finally, a lot of these patients, especially those in advanced stages, will have liver congestion, chronic kidney disease, and have bleeding risk, which has implications for anticoagulation when we talk about valve replacement strategies. So when you look at TR distribution in the community, 90% of these patients are functional TR, as I mentioned, resulting from left-sided heart failure, left-sided valve disease, or pulmonary hypertension. A small proportion are isolated TR or congenital TR or other etiologies, including heart failure and heart transplant patients. Importantly, the outcomes are dismal over a 5 to 10 year period. Based on some of the studies, the 10-year survival in these patients with severe tricuspid regurgitation is 14%. This is a paper that was published by some of our fellows. They looked at the mortality associated with tricuspid regurgitation over the last 20 years. And this seems to be increasing over the past 2 decades. And there could be various reasons for this. Patients with heart failure are living longer because they have better drugs. Patients with valve disease are getting transcatheter interventions, which perhaps in the past was not the case. And so these patients are living longer. And ultimately, they're presenting with right-sided heart failure and tricuspid regurgitation. There's a wealth of data on impact of tricuspid regurgitation on survival and mortality. This is just a couple of examples looking at over 5,000 patients with heart failure. And when you look at this 5-year follow-up, there's sort of a graded response. As the TR severity increases, the survival goes down. In this series, the 1-year survival was 63% in patients with severe tricuspid regurgitation. We see a lot of patients with multi-valve disease. We do mitral edge-to-edge repair for patients with mitral regurgitation and TAVR for patients with aortic stenosis. And often these patients have concomitant significant TR. This is a paper that was published by one of our residents, which looked at the impact of tricuspid regurgitation on MTR outcomes. And not surprisingly, patients with severe tricuspid regurgitation had worse outcomes despite successful mitral edge-to-edge repair. Similarly, this is a paper from the STS-TVT registry, which was published, first author paper by Yasser Samor, one of our fellows, who looked at the impact of baseline tricuspid regurgitation on the health status outcomes such as KCCQ and quality of life in patients undergoing MTR and TAVR from the STS database. And clearly, the outcomes were worse in patients with significant tricuspid regurgitation. In addition, hard endpoints such as all-cause mortality, readmission, heart failure readmissions were also significantly worse in patients with worse degrees of tricuspid regurgitation compared with lesser degrees of tricuspid regurgitation. What about surgery? There are prominent surgeons in the room. I'll just make a few points. There has been low penetration of cardiac surgery for tricuspid regurgitation in general. When you look at the numbers, there are over 1.6 million cases of tricuspid regurgitation. However, there are less than 8,000, probably 10,000 now, annually in the United States. So less than 0.5% of the cases with significant tricuspid regurgitation undergo surgery. And this just sort of puts this in perspective. When you look at the aortic stenosis, about 14% of these patients get treated. When you look at mitral regurgitation, which is the bulk of the valvular heart disease, 1.5% of patients are treated with surgery. When you look at tricuspid regurgitation, out of 1.6 million, only 0.4% of the patients actually undergo surgery. So there's a huge unmet need for transcatheter treatment. What about outcomes of isolated tricuspid valve surgery? I have a couple of slides. This is data from the Mayo Clinic group. Actually, these are data from the national registries. The number of the temporal trends in surgical volume seem to be increasing. There are more tricuspid valve surgeries that are being performed. These data are from 2004 to 2013, over 5,000 surgeries. Mean age was 62. In-hospital mortality was 8.8%. You can see on the table on the top right, cardiogenic shock 6%, pacemaker 26%, and so on and so forth, all the other outcomes. In-hospital mortality was higher for tricuspid valve replacement compared to repair, odds ratio of 1.9, and factors associated with increased risk of mortality after tricuspid valve surgery included coagulopathy, end-stage renal disease, valve replacement, and Charlson comorbidity index. Important to recognize, the mean age in this cohort was 62. This becomes important, so pay attention to the mean age in these populations. So mean age of 62, mortality of 9%. These are more recent data published by Vinod Turani and others from the STS Adult Cardiac Surgery Database, more contemporary also, 2017 through 2023, more than 13,000 patients. Mean age was 48 in this cohort, 41% underwent repair, 59% underwent replacement. Overall mortality was lower, 5.6%, with mortality of 5.4% for valve repair and 5.7% for replacement. However, again, important to note that the mean age was 48 in this cohort of 13,000 patients from the STS database. Moving on, some couple of important anatomical characteristics that are important for transcatheter tricuspid interventions. There are new stages or severity of tricuspid regurgitation. Traditionally, all valve disease has been mild, moderate, or severe, but now we have massive and torrential as stages of tricuspid regurgitation. And this becomes very important when we talk about severity of TR and the results and the outcomes. So this is a brief classification. I'm not going to go into a lot of details. I know Dr. Steve Little is going to give an excellent grand rounds next week on imaging in structural heart disease. But this is, just for your reference, the new stages of TR, and you can see what this massive and torrential mean. And a lot of patients have this type of severity. The other important anatomical thing that we have learned over the last few years is that not all tricuspid valves are tricuspid. This is a classification scheme proposed by Becky, Han, and others during the TriLuminate trial. And you can see sometimes these anterior leaflets, posterior leaflets, or septal leaflets can have scallops. This becomes relevant when we talk about edge-to-edge repair in particular to decide which leaflets are we actually going to clip. So this is an example of how these leaflets are classified. So moving on to the tricuspid transcatheter landscape. So there are various devices, as you all are aware, that are being studied, which range from annuloplasty devices to coaptation enhancement or edge-to-edge repair techniques such as TriClip, Pascal, to orthotopic valve replacement, including Evoque, Intrepid, and others as listed, heterotopic replacement, and spacer type of devices. So there is a plethora of devices that are being studied over the course of the last several years. We will focus on two devices that are now approved as of 2024. In fact, earlier this year, the first device to be approved by the FDA in the United States was the Evoque TTVR device, which is a valve replacement. And a couple months later, the FDA also approved the tricuspid clip for treatment of severe tricuspid regurgitation. So the way I look at this is, what are the main questions? When you see a patient with tricuspid regurgitation, who should be treated? So who or patient selection? What outcomes should be studied or expected to improve? When should you treat this patient in the spectrum of presentation? And how should you treat them among all these devices? So let's tackle each of these questions one by one. I think the main focus is going to be who. So who was studied and what were the outcomes? So we'll talk briefly about the two main trials, the TriLuminate and the TriScend. The TriLuminate was published in the New England Journal of Medicine last year. This was a pivotal trial designed to evaluate the safety and efficacy of the clip in symptomatic severe TR patients who are deemed to be intermediate or high risk for mortality with surgery. This is the device. We're all familiar with the clip. We've been using MitraClip for about 10 years now, and this device has undergone several iterations, and we now have 4 different clip sizes. So the clip is the same. What is unique about the TriClip system is actually the delivery system. The delivery system has been designed for the tricuspid valve due to the anatomical differences compared to the mitral valve. But the clip itself is still the same, and we have 4 options to choose from. So this was the device that was studied in the TriLuminate, and this was a randomized trial. Patients were randomized 1-to-1 to the TriClip device plus medical therapy versus medical therapy alone. Here are the key inclusion and exclusion criteria when you think about who was treated. So they had to have severe symptomatic TR. They had to be on stable GDMT for more than 30 days, and they had to be intermediate risk or high risk for surgery. Patients who were excluded were patients with other valve disease, such as severe aortic stenosis or severe mitral regurgitation. Those had to be treated first. Patients who had severe pulmonary hypertension, typically more than 70 or typically defined as more than 2/3 of systemic pressure. Patients with very poor left ventricular ejection fraction, less than 20%. And of course, anatomy not suitable for tricuspid clip. And we'll talk a little bit more about who those patients are. The primary endpoint was a composite endpoint, as you can see, of mortality, tricuspid surgery, heart failure hospitalizations, and quality of life improvement assessed using the KCCQ score, evaluated at 12 months in a hierarchical fashion. And there's a whole bunch of secondary endpoints. 450 patients were enrolled in 80 sites in US, Canada, and Europe. And let's go over the baseline characteristics. It's important to see who these patients are. So mean age was 78. Remember, in the surgical series, the patients were 62 and 48 So these are much older patients. We're not talking about treating patients in their 50s or 40s with transcatheter therapies. These are older patients. Most of them have an NYHA class 3 or 4 symptoms. Most of them have atrial fibrillation, which is chronic. 15% of these patients had leads in the TriLuminate study. Vast majority of them, 95% of them, had severe massive or torrential, and you can see almost 75% of these patients had massive or torrential, so more than severe tricuspid regurgitation. Most of them had preserved ejection fraction, and you can see the RV size, the tricuspid annulus diameters, just to get a sense of where these patients are in the spectrum of where of this disease. And the gaps were about 5 millimeters. The gap, which is the distance between the leaflets that are being clipped. And again, not surprisingly, vast majority have functional tricuspid regurgitation. So here's the primary endpoint, which is a composite endpoint. And tricuspid clip was superior to medical therapy in terms of the primary endpoint, the composite endpoint. And this was determined with a win ratio-based analysis. And the statistically significant result was driven by improvement in quality of life as assessed by the KCCQ score. Importantly, there was no difference in the hard endpoints such as mortality or need for tricuspid surgery or heart failure hospitalization. So this was a little bit of a surprise for all of us. We were all expecting that patients will have improvement in heart failure hospitalizations and perhaps even mortality. Perhaps it was a little bit naive to expect mortality benefit in patients with tricuspid regurgitation. These are generally, further in the stage of heart failure, more advanced patients compared to aortic stenosis and mitral regurgitation. Be that as it may, the primary endpoint was positive, and this was driven by KCCQ improvement at 1 year. The 2-year data are going to be presented later this month. Here are the Kaplan-Meier curves. Again, mortality or tricuspid surgery, no different. The heart failure hospitalization, again, at 1 year, no different. It'll be interesting to see what these curves look like at 2 years. Perhaps over long-term follow-up, we'll see an improvement or reduction in heart failure hospitalization. The quality of life improvement is important. This is a very important metric when we see heart failure patients. And when you look at the patients who have more than 5-point, 10-point, 15-point improvement, they were all in favor of patients treated with the device or the TriClip. How does a device do in terms of reducing TR? We're talking about reducing severe massive TR. So as you can see, these are the baseline data. 99% of patients had severe massive or torrential. In the control group, there is no change. Most of them stay in the massive torrential or severe group. However, at 30 days and 1 year, there's sustained reduction from 98% of the patients in the severe massive or torrential group to about 87% in the moderate or less severity. So there's substantial reduction in the severity of tricuspid regurgitation. And this is sustained out to 1 year, 89% with moderate or less. So it's not perfect. It's not mild or less, but moderate or less, in contrast to the mitral regurgitation studies. And when you look at the relationship between the TR severity or the residual TR and the quality of life, patients who had moderate or less residual TR had a significantly higher KCCQ score compared to patients who still had persistent severe massive or torrential TR, not surprisingly. What about safety? How safe is this device? So this is important. Cardiovascular mortality 0.6%, adverse event 1.7%, and no need for non-elective cardiac surgery. Single leaflet device attachment is an important one. That was about 7%. This is similar to the original TriClip data, which was about 10 years ago. In the Everest trial, the SLDA rates were about 6%. Now the SLDA rates are about 1% or less with the mitral. So this is only expected to get better as we gain more experience with the device, as our imaging capabilities improve. And we'll talk about the imaging. Need for pacemaker or devices is very, very low, 0.6%. So overall, based on these data, you can see that the device is very, very safe. The procedure is very, very safe. And the risk of major adverse events is extremely low. So in summary, TR was reduced by tricuspid clip to moderate or less in 87% of patients, which is sustained out to 1 year. The primary endpoint was met, which was driven by improvement in quality of life. And the degree of TR reduction correlated with the degree of improvement in quality of life. And again, this is a very, very safe device. Important point is the last one, which is survival-free of mortality at 1 year was 90%. So 1 year mortality actually was specifically about 9%, and this is important. And we'll talk about this why. So when you look at the patients that were treated, you also have to see who are the patients that were excluded. Like any other trial, a large number of patients get excluded for various reasons. So they screened about 1,500 patients, and only about 350 patients actually ended up in the trial. And you can see that many patients were excluded for various reasons, ranging from clinical to anatomical. And we looked at our own population. This is a paper published by Taha, who is our research fellow, who's now a resident at Cleveland Clinic. We looked at all our screen failures for triluminate, and when we looked at reasons for screen failure, vast majority of them were clinical. They either had severe pulmonary hypertension, or they were on dialysis, or they had significant left-sided valve disease, and so on and so forth. About a fourth had large gaps or anatomical reasons for screen failure, and a small number had leads in the grasping zone. But importantly, this was an important finding for us. We found that their one-year mortality was 32%. So this is in stark contrast to triluminate, where the one-year mortality was 9%. This tells us that in real world, when we are consulted for these patients are far sicker than what were enrolled in the triluminate randomized trial. So this is not surprising, but it's important to note that the mortality is 4 times what we saw in the triluminate study. And then there are similar other data from Europe. When you look at the data from, this is almost 1,000 patients at 5 European centers, they applied the triluminate criteria to these patients. 55% were eligible for triluminate, 45% were not eligible for a variety of reasons. The TR reduction, NYHA improvement, quality of life, etc. were comparable in eligible versus ineligible patients. But one-year survival, as you can see in the Kaplan-Meier curve, was significantly lower in patients that were ineligible according to the triluminate criteria compared to the patients who are eligible. So, when we see patients in real world, like anything else, these patients tend to be sicker than patients that are studied in the randomized trial. And this was seen in the European data. So this brings us to the single arm. There was also a single arm in the triluminate where patients were not randomized. These are patients who were deemed to be having a low likelihood of achieving moderate or less TR, when considering TR severity, coaptation gap size, or presence of leads. And you can see that the degree of moderate or less residual TR was a little bit less in the single arm compared to RCT arm, 81% versus 89%. However, when you see the mortality and the heart failure hospitalization, in the single arm, the mortality was 15%. Compared to 8.6% in the randomized arm. Heart failure hospitalization was 24% versus 15%. This is 1 year in the RCT arm. And David Adams, who's the surgical PI for the triluminate, said, had we known what we know today, we might have put everybody in the randomized cohort. It would have been an interesting study if we could have predicted this and randomized all patients rather than perhaps cherry-picking patients and putting the not-so-sick patients in the randomized and the patients who are perhaps not as straightforward in the single-arm study. Anyway, this is all speculation. So I'm going to share a case, after sharing all this data. This is an 82-year-old gentleman that came to us, history of chronic atrial fibrillation on anticoagulation, prior pacemaker lead, some comorbidities, worsening lower extremity edema, NYHA class 3, despite medical therapy, including diuretics and SGLT2 inhibitor. He was hospitalized, diuresed, optimized medically. Despite this, he had ongoing symptoms and severe TR. He was clearly felt to be a high risk for surgical intervention. And these are some of his images. The TEE clearly shows severe tricuspid regurgitation. And you can see the gap between the leaflets, although the gap is not very big. Here, the gastric view. This is a very important view for us when we do tricuspid edge-to-edge repair. You can see the lead is sort of in the posterior aspect of the valve. This is septal leaflet, anterior leaflet, and posterior leaflet. And bulk of the regurgitation is central and also in the anterior and septal, between the anterior and septal leaflets of the tricuspid valve. When you look at the triluminate data, vast majority of patients had clips between the anterior and the septal leaflets, small number between the posterior and septal and the anterior posterior. So this is sort of the preferred zone, and this is where most of the regurgitation occurs for tricuspid valve. So our protocol is typically to orient the clip with the transesophageal echo. This is on the bottom left, you can see the transgastric view. So we are orienting the clip perpendicular to the line of coaptation of the anterior and the septal leaflets. So the clip arms are oriented sort of 2 o'clock, 8 o'clock. And this is the corresponding 3D view from the right atrium. You can see the lead is in the back. And here we are orienting the clip between the septal and anterior leaflets. We also use multiplanar reconstruction. And then grasping, we used to do all of this with TEE. But we have found, as have others, that with intracardiac echo guidance, this is a complementary imaging technique to TEE, and you can see the leaflets very clearly. As you can see on the right side, the grippers are bouncing, and we are very confident that we have grasped the grippers. So this has sort of become our protocol now, and you can clearly see that these leaflets are taut. There's some residual regurgitation posterior to the clip. We go back to the TE, look at the transgastric view. The clip is nicely attached to the anterior and septal leaflets there with some regurgitation posteriorly. And similarly, in the short axis view, we can see the clip in the anteroseptal and residual TR posteriorly. And then we go back in with the second clip, again orienting with the TEE. So we're going back and forth, as you can see, between TEE and ICE guidance. And we use the 3D Philips ICE probe. That's logistically very easy because we have the same machine. We don't have to switch between different consoles. The console is there. Dr. Little or Dr. Faza is on the left side of the patient with the console. And our ICE catheter is plugged into the TE machine. And it's very easy to toggle back and forth between the transesophageal echo and intracardiac echo. So again, we orient the second clip, as you can see here, and then we grasp with the help of ICE. And you can see the grippers bouncing. And final assessment with TE, of course, and we have mild residual tricuspid regurgitation with 2 clips in the anteroseptal position and corresponding 3D color image here. So this is a typical example of what we are seeing lately, since we launched our commercial tricuspid clip program. I think this is a very complementary imaging technique, both TE and ICE. If the ICE images are outstanding, then we don't necessarily need TE, but sometimes the TE, I think, provides additional guidance. Here is another example. This is the previous case was functional TR. This is an example of a patient with a flailed septal leaflet, prior heart transplant, presumably related to some biopsies, and very nicely treated with 2 XTW clips, again in the anteroseptal location, and you can see the gastric views in the bottom. There's very mild or trace residual tricuspid regurgitation. So what is our protocol? So, we diurese these patients, of course. First thing is to diurese them. We do right heart catheterization to measure the filling pressures after this, measure the wedge pressure, PA pressures. We optimize their left-sided heart failure. This is how these patients were studied, by the way, in the TriLuminate and the TTVR studies, and we follow the same protocol. We try to reduce their wedge pressures and try to get this close to normal, or at least less than 20 if possible. If severe TR persists, then we evaluate them with a protocolized transthoracic echo, which is a little more detailed for tricuspid assessment compared to a regular transthoracic echo. And then if they have severe tricuspid regurgitation, then we move on to a comprehensive 3D evaluation to assess suitability for edge-to-edge repair or TTVR. And then we have a multidisciplinary team discussion regarding surgery, edge-to-edge repair, TTVR, or other options. If we decide to go with TTVR or edge-to-edge repair, then we admit these patients a couple of days before. We diurese these patients. The tricuspid valve is much more volume sensitive compared to the mitral valve. We find that this helps in reducing the gap and being able to grasp the leaflets better. And then we do the TEER procedure with ICE and TE guidance. So this is sort of our one-page protocol for how we handle these patients. So that was TEER. Now moving on to the other part is TTVR. So we'll talk a little bit about the Medtronic Intrepid system, which we have a lot of more experience with, I should say. The Medtronic Intrepid system is there is a circular inner stent which houses a 27 millimeter bovine pericardial valve and an outer conformable stent which anchors the leaflets without capture or atrial protrusion. There's a 42 and a 48 millimeter valve that is available with an XL valve in development. And this is a transfemoral device, 35 French sheath. This can be inserted via cut down, or now people are using more and more percutaneous access with ProGlide. And this is an example of what this looks like. This is one of our cases. We have a pacemaker wire in the left ventricle through which we can pace if needed. And this is the delivery. And this is a final fluoroscopic appearance of the valve in a patient with severe tricuspid regurgitation. And this is corresponding echo images. This patient was treated last year and is doing very well with no residual tricuspid regurgitation. As you can see, the major advantage of the valve replacement is that it eliminates tricuspid regurgitation in contrast to CLIP, where there's still some residual tricuspid regurgitation, which may have other implications that we'll talk about. The Evoque valve, this is a valve, the Edwards valve, that is now approved by the FDA. This is made from bovine pericardial tissue. There's a nitinol self-expanding frame with an intraannular sealing skirt and frame, and there are 9 ventricular anchors which are designed to engage the leaflets, cords, and enable a secure placement. So this is the valve that was studied in the TRISCEND study. This is also a transfemoral delivery system, 28 French outer diameter. And this is a brief procedural animation as to how this procedure is performed. Again, transfemoral venous access. There's a ventricular wire that is used in contrast to the Medtronic Intrepid system. And as you can see, this is done with fluoroscopy and, of course, echocardiography guidance. And initially, the ventricular part of the valve is exposed. These anchors come out. These are now advanced into the ventricle, and then the subvalvular part is engaged, and then the valve is slowly extruded in a controlled manner in an intraannular fashion, as you can see here. And that is basically the deployment of this transcatheter tricuspid valve. Here's a case example that was shared by Dr. Pradeep Yadav, who is a close friend and a colleague at Piedmont Heart Institute. And you can see the corresponding fluoroscopy and intracardiac echo MPR views on the right side here. This patient, or TE views, I'm sorry. The valve device is advanced, the trajectory is checked, the ventricular part of the valve is exposed, and you can see this on fluoroscopy on the left and the echo images on the right side. And finally, the valve fully deployed. In this patient, of course, there is a lead, and the lead is trapped. So all these transcatheter valve replacement studies, they have electrophysiology as part of the team, in addition to imaging, interventional, and surgery, to assess these leads carefully, to see if these patients are pacemaker dependent, to see if there is a backup option for pacemaker, and so on. So leads in the setting of TTVR is an important topic that always comes up and is being discussed very thoroughly going forward. So some of the data on the Edwards Evoque valve, this started with some European experience, followed by the single-arm TriScent study, and then the randomized TriScent 2 study, which was the valve versus medical therapy. So this was a 2-to-1 randomization between the Evoque plus medical therapy versus medical therapy alone. These patients will be followed annually through 5 years. So these are some of the baseline characteristics of these patients, kind of similar to the Triluminate. You can see the mean age was 78, 79. A large proportion, this is different, large proportion of these patients were women in the TriScent 2. Almost 80% of the patients had NYHA class 3 or 4 symptoms. They have the high STS scores, 9%, 10%, as you can see. Again, preserved ejection fraction in most of these patients. Vast majority have atrial fibrillation, and more patients in the TriScent 2 had leads. So 36%, 40% here compared to about 15% in the tricuspid clip. And most striking, of course, not surprisingly, is that TTVR effectively eliminates TR in a vast majority of patients, despite the presence of massive or torrential TR in more than 50% of the baseline. So on the left side is the baseline, and on the right side you can see the 6-month result. Here is on the left, here is the Evoque plus OMT arm, where 94% had mild or less tricuspid regurgitation at 6 months. So the replacement device is very good at eliminating tricuspid regurgitation, in contrast to the clip, where there's still some residual tricuspid regurgitation. Again, the patients experience improvement in quality of life, 6-minute walk distance, KCCQ score, NYHA class, which is comparable to what we saw in the tricuspid clip. This is an important slide, the safety. How does it compare to the Triluminate? So here the mortality was 3.2%, so still low, but if you remember the previous slide that I showed about Triluminate, the mortality was 0.6%. Severe bleeding, 10.5%. These patients have to be anticoagulated after a valve replacement, in contrast to tricuspid clip, where DAPT is enough, unless they have atrial fibrillation and they need anticoagulation for that anyway. This device is much larger. The delivery system is larger compared to the clip device. And then 14% patients required permanent pacing. Remember, anatomically, the AV node is very close to the annulus, and once you put this valve, depending on the radial strength and baseline conduction abnormalities, patients may need a pacing device. So sometimes we see tricuspid regurgitation associated with a lead, and so this becomes a challenge sometimes as to how are you going to pace them. You can you try not to put a new lead through the fresh valve. You can do leadless pacemaker or coronary sinus pacing. So this is an active discussion that has to be had with the patient, with the electrophysiology team, as to what is going to be the way to pace these patients if they need a pacemaker after a valve replacement. So these are important discussions. Again, some of the data are going to be presented at TCT, but the available data that we have shows favorable trends in mortality and heart failure in favor of the Evoque plus medical therapy compared to the medical therapy alone, and similar improvements in functional and quality of life outcomes with the device compared to medical therapy alone. The trick valve, this is an interesting device. This is a heterotopic bicaval system where you put a stented valve in the superior vena cava and the inferior vena cava. You don't do anything to the tricuspid valve. The proposed benefit of this is that these valves shield the systemic circulation from the regurgitant volume, regurgitant flow going back into the superior and inferior vena cava. And there are some mechanistic studies actually that show that there is favorable reverse remodeling of the right side of the heart after these trick valves are put in. There are some data from Europe. We are part of the initial study in the US called TriCav. We've had some experience with this device as a compassionate use device last year, but we're excited to enroll patients in the TriCav-1 study, which is the initial feasibility study, which will be followed by a larger study for this valve. The main advantage of this valve seems to be the ease of use in contrast to the tricuspid clip, and safety also may be favorable compared to the conventional TTVR systems. But again, we need more data. So what other important outcomes? So we talked about, this was large part of the talk, is who are the patients that are being treated or were studied. So what other outcomes may be important? We learned from TriLuminate that quality of life is what won the trial. The mortality and heart failure did not. So the TEER is the VARC that has been set up for tricuspid regurgitation and study the outcomes. There are perhaps other outcomes that need to be studied. All these patients will have liver congestion, they have renal dysfunction, they have protein losing enteropathy, they are, some of them become cachectic. So perhaps there are some of these markers that should be studied or incorporated, and we should study this post-tricuspid intervention, be it clip or a replacement device. When? This is a very important question in my mind. When should you intervene in relation to both the severity of TR and also the RV function? So there are some data, not a lot, but some data. So we talked about the moderate, severe, massive, torrential. These are data from the TriValve registry from Europe, and they looked at the risk of death or heart failure hospitalization after tricuspid clip, stratified by the severity. So in blue, you have severe TR, and in the red is the massive or torrential. And over 12 months, they found a favorable outcome in patients with severe TR, but massive or torrential did worse, not surprisingly. These are more advanced, they are sicker patients. Similarly, the heart failure hospitalizations alone, that was much worse in patients with massive or torrential. That would suggest that perhaps we should not wait for the TR to become massive or torrential, and we should consider treating these patients earlier in the spectrum. How about the RV function? This is a bigger challenge. So this was again from the TriValve registry. They studied about 700 patients who underwent transcatheter tricuspid interventions versus 900 patients who underwent conservative treatment. They did a propensity matched analysis, and outcomes were stratified by TAPSE, which was used to study the RV function. And the 1-year mortality was 13% in the intervention arm versus 26% in the medical arm, so significant in favor of the intervention. But when they stratified these patients by the TAPSE, they found a U-shaped relationship. And what that means is patients who have a reduced TAPSE less than 13, there was no difference. Patients who had preserved TAPSE more than 17, there was no difference. But in between, patients with TAPSE between 13 and 17, there was a benefit of the intervention compared to medical therapy. Again, these are non-randomized data, these are propensity-matched analyses, but this perhaps gives us a clue that maybe in the patients with normal RV function who have not massive or torrential, maybe we can manage them medically and they may do okay, but we should certainly not wait for the patients to develop advanced RV dysfunction in conjunction with torrential or massive. There's a sweet spot in between where some of these patients may benefit. And I think the onus is on future trials to look at this carefully. Of course, is TAPSE the best way to study the RV function? Should we be looking at MRI? So there are all these questions that our imaging colleagues will also help us answer. So last question is how? How should you treat them? Should you do a TEER, or should you do a TTVR, or some other way of treating the tricuspid valve? There's no randomized study, right? So what we know so far is large coaptation gaps, not surprisingly. These may be very hard to clip. So if somebody has a very large coaptation gap, despite aggressive diuresis that doesn't shrink, then you should consider transcatheter tricuspid replacement, because a clip is unlikely to work in this scenario. And this was one of the main reasons patients got excluded in the TriLuminate. If the pacemaker or the ICD lead is in the grasping zone, then of course these were the patients that were excluded from TriLuminate. Having said that, we've also seen, including our center, we've done some cases where the lead is in the way, but with the help of an Agilis or a steerable catheter, we gently sort of nudge the lead out of the way. And we try to be as gentle as we can so as to not anger our EP colleagues and not dislodge the lead. But this was, at least in the study, these were excluded. If the lead is not in the grasping zone, then these patients were included in TriLuminate, and clinically we also have treated these patients successfully. So leads is the other issue. One is the coaptation gap, the other is the leads. And then the anatomy. The IVC entry into the right atrium is very variable. So we are starting to study this with CT, and this is not uniform. Sometimes the anatomy is very challenging, and with the current delivery systems, this can be a no-go. So these are important anatomic, in addition to, of course, annulus size and the sizes that we have available. And lastly, the question that comes to everyone's mind is, what about RV failure? When you take away this pop-off and you suddenly increase the RV afterload, is the RV going to fail? So there's not a lot of data on this, but there's some data from Europe again. This was again from the TriValve registry from Europe. They had 500 patients. And this is not exactly RV failure. We're still trying to figure out how to define RV failure after TTVI, but they studied this concept of low cardiac output syndrome after tricuspid transcatheter valve repair. And this was found to be present in about 2.8% of the patients. So 14 out of 500 patients had this. But importantly, this was associated with in-hospital mortality. So in patients who had this low cardiac output syndrome after transcatheter tricuspid intervention, their mortality was 43% versus 1%. Again, small numbers, but this is something that we need to be cognizant about. And there are some predictors here. Patients who already had hemodynamic instability, they had some LV impairment, chronic kidney disease, biventricular impairment. Not surprisingly, these are sicker patients. But this is an area of active investigation as to how we can predict or prevent this. And there have been, I think there has been only one case reported in the literature, to my knowledge, of acute RV failure after tricuspid valve repair or tricuspid edge-to-edge repair, because there is still some residual TR. Whereas the concern with valve replacement is perhaps that this may be a higher risk as we treat patients with RV dysfunction. Although in the clinical trials, patients with advanced RV dysfunction were excluded. So this is sort of a summary slide, the way we think about this. So the strengths of the tricuspid TEER, I think, are safety. Shorter length of stay, RV failure is unheard of. Strength of TTVR is elimination of TR, agnostic of coaptation gap. There are limitations to both. Limitations to TR can be large gaps, anatomies may not be favorable, you may not get a desired result. There may be leads, residual TR, no TTV option in the future if they have recurrent or progressive TR yet. And imaging requirements, of course, we need excellent imaging, which we are very lucky to have here. And then the limitations of TTVR can be large annuli. These valves don't exist yet. The angle, the anatomy that we talked about, the need for oral anticoagulation. We don't know a lot about durability of these valves, risk of halt and thrombosis, which we've seen with other valves, jailed leads and their implications, and of course, risk with RV dysfunction. And then the complications as shown there, which are rare with tricuspid TEER, but that is a concern with TTVR. I think that is my final slide. So in conclusion, I think this is a great time for severe TR patients and transcatheter TR therapy. We now have 2 FDA-approved options. We still need data, a lot of data on longer-term outcomes, on the optimal device, valve replacement versus edge-to-edge repair for individual patient, the timing of intervention, and the optimal outcomes, including lab data, imaging data to be studied in this population. Thank you very much.
Thank you, Dr. Goel, for an amazing update on where we are in tricuspid valve. We'll take opportunity for several questions here. Dr. Nasser.
Sachin, this was one of the best grand rounds I've listened for the last 1 year. So thank you so much for educating us.
Thank you.
Key things came to my mind and would love to your comments. So clearly, the first thing you showed that a significant, almost 99% of individuals with severe TR don't even get the intervention that's needed. Do you think there are system-wide approaches, maybe big data, that can identify these individuals, referral to valve clinics? Some of those programs can be considered. So that's one. Second, it seems like not all severe are the same. How can we identify much earlier, even the moderate to severe, to see who may benefit the most, because clearly once you have passed a certain point, there's no return. And thirdly, are there any preventive measures once you have identified the moderate or maybe the mild, or in that scenario where we can help prevent them to a point that they may need the intervention, either surgical or percutaneous? So again, thank you so much for educating us on this.
Thank you, Khurram, for the kind comments. Great questions. So for the first question was AI. Yes, AI, I think, can play an important role, is playing an important role. We've learned from other valve therapies, including aortic stenosis and mitral regurgitation, how AI and big data can identify some of these patients. We've seen from data from Boston, from the Harvard group, how vast majority of AS patients are actually not treated. And there's huge undertreatment of AS, MR, and I'm sure tricuspid regurgitation. So AI can play an important role, and I think system-wide approaches can be used to identify these patients. The second question was the prevention. So I think prevention is important in cardiology. We are all preventive cardiologists, to varying degrees. I think a lot of these patients are chronic heart failure patients. A lot of these patients may have prior valve interventions. So the way I think of this is valve intervention is not a one and done deal. These patients have underlying myocardial dysfunction, and they should be appropriately medically managed. If you cannot manage them, then you should consider heart failure evaluation. They need to be on all the approved indicated heart failure medical therapies to prevent RV dysfunction. And if they continue to have progressive disease, then of course tricuspid intervention is a growing option for these patients. And I'm sorry, what was the third question?
Just identifying maybe
Moderate to severe, yes, the severity. Severity, yes. So yes, you're absolutely right. So all these echoes that we are doing in these patients are very, very focused echoes. With the help of Dr. Little and others in the department, we established a protocol, and these are extensive, these are more time consuming, and yes, we are identifying more patients that would otherwise perhaps be categorized as less than severe. So I think we do need good quality imaging across the board, and identify some of these patients earlier and prevent them from ending up with torrential regurgitation, where we are learning that the outcomes may not be as good despite a successful intervention. Steve, yes.
Sachin, so masterful, as expected, particularly your TE images, really nice. So question for you about cost effectiveness. All right, so you very nicely demonstrated TR, bad TR, bad prognosis, 90% is secondary. So far, we don't have any compelling data about a mortality benefit, although we have trends in Evoque. But we have questionable stuff about reduced hospitalization, depending which data set you look at. But really, it's patient-reported symptoms that we have improvement for. So these devices are very expensive. They're between 30 and 50% more expensive than TAVR devices that we have mortality benefit for. So enormously expensive, no mortality benefit so far. We're expecting a tsunami of activity, but our hospital system is really going to pay for this.
Yeah, that's a great question, and that is one of the biggest discussions that is going on is how do you justify these trials where patient-reported outcomes, there was no placebo-controlled arm. I think it's very difficult to do a placebo-controlled trial in such a space, but I think the point is well taken that the hard endpoints are not there, and that's why I think we need to focus on what are the outcomes, what do we expect. We are all obsessed with mortality. Yes, we would like to reduce mortality. Stents don't reduce mortality for PCI in stable coronary artery disease, yet we use them all the time. The quality of life is important. Just like we use stents for stable angina, patients feel better, and I think the patient-reported outcomes are important, and I think there is a lot to learn about these patients.
There's a couple of things about cost. It's not just hospital. I mean, you have to pass the FDA to get your device approved. Then you have to pass Medicare to get it paid for. And the problem is we're seeing these devices get approved but not paid for, and that becomes even more problematic. I mean, it's not Medicare paid for, they probably wouldn't pay enough. Evoque is very, very expensive. But we're going to have a hard time getting the payers to pay for something without some sort of mortality benefit. So I think it's going to be a real conundrum going forward.
So Sachin, really fantastic talk. I want to just probe you a little bit. You touched on this a little bit with regard to RV function, RV health. as maybe one of the criteria that you can look at for patient selection. And my question to you is, we've got ways of looking at RV strain or TAPSE or RVEF, but to some extent, you correct for the amount of tricuspid regurgitation, because it may be different in somebody who's got 150 cc's of TR versus somebody who's got 50 cc's of TR, what the implication of any given RV ejection fraction is. And so how do you take that into account when you're deciding patient selection for these patients?
Yeah, that's a great question, Deepan. I don't think we know clearly how to sort that out. There was a imaging sub-study in the TriLuminate. I think the data are going to be presented at TCT in a couple of weeks. Similarly, the Evoque, all these trials have imaging sub-studies with CT or MRI or both. We need to lean on you and our imaging experts in sorting this out. The same thing happened with, not same, but when we looked at COAPT versus MITRA FR, the major discrepancy was, one trial was positive, the other was negative, and we came up with this disproportionate concept, looking at EROA versus volumes. Perhaps it's not just EF. The volumes may be important, and perhaps a similar framework needs to be constructed for the right side. And also, I didn't talk about that in the interest of time, but the RV-PA coupling is very important. The afterload reserve that is assessed with the RV function and the pressure, that has been shown to be an important prognostic marker in these patients. So I think there's a lot to be learned, not only about imaging, but also the hemodynamics and how these can be used in patient selection.
Dr. Lowry.
Oh, excellent talk, Sachin. Just speaking from the surgical point of view, you did accurately quote the STS data overall, but the study did indicate a declining trend in mortality over the period of the study, and I think the surgeons have been learning the same lessons, and together we've been learning a lot more about the preparation of these patients. I've personally got a series of over 350 tricuspid repairs of all different types with 3% mortality, but as a result of having, for a number of years, been emphasizing very rigorous stabilization of these people. The other question I had was the extent of medical therapy continuing after the procedures. Has that been studied in these trials? Obviously, many of these people will need to be on some significant amount of medication after their treatment.
Yes, that's a great question. So the first point, I agree with the preparation of the patient. I think the TR patients are different from the aortic valve patients, for instance. The aortic valve patients come in, we do the TAVR or you do the SAVR, and they go home after a period of observation. But the TR, I think, right side, we have to bring them in for a few days, optimize them, diurese them, and I think that is key point. The second question about the medical therapy after the intervention, in both of these groups of trials, the TriLuminate as well as TriScend, the medical therapy was continued. It was encouraged not to make any changes to the medical therapy despite a successful intervention. In follow-up, when patients are assessed in terms of volume status, then sometimes we have to reduce their diuretics. But other therapies like SGLT2 inhibitors or ACE inhibitors or beta blockers, those need to be continued, because vast majority of these patients have left-sided heart failure, pulmonary hypertension, and have other indications for these therapies. These therapies are not specifically, designed for TR. I mean, when you look at optimal medical therapy for TR, it's only diuretics, but by virtue of the underlying pathophysiology, they do need other GDMT, depending on whether they have LV dysfunction or other left-sided heart failure. So those are encouraged. We continue those always.
And really, the reason I was just wanting to revisit the mortality issue with surgery is that when you've reviewed these patients, you have a difficult problem, and you don't think they're ideal candidates for an intervention, then surgery, I believe, in an experienced center with experienced surgeons who have experienced interventionalists, are in a position to offer a surgical solution to the patient's problem at a similar level of risk to the interventional problem. Obviously, we'd prefer the interventional, but it shouldn't be a sequence of assessing them for intervention, and then if they're not able to be intervened, viewing surgery as a prohibitively dangerous thing that should not be offered to them. I think just the opposite now. We can look after some of these people who aren't candidates for the intervention.
Absolutely. I think the heart team is critical as ever.
Sachin, great talk as always. Going on further with Dr. Laurie's discussion there, some of the older surgical literature had included patients with endocarditis, younger patients, and not the greatest outcomes. Some of the later data that you presented there with the decline down to 7% or so in the most recent STS database. Survey of isolated tricuspid surgery excluded patients with endocarditis. So my question is, these days, who should we offer, which I guess wasn't really kind of touched on, who should we offer surgery to these days?
Yeah, I think that's a great question. So, in these trials, patients were deemed to be high risk for surgery. So, when we see these patients, as we see them together with you or Dr. Reardon or other surgeons. So if the surgeon says that, hey, I can operate this and I can operate on this patient with a low risk of mortality, then I think surgery is the way to go. Because surgery has been around for a long time. We know a lot more about surgery and the durability and the outcomes. But if surgery is a high risk situation, when these patients have liver disease, when they're getting ascites or renal failure, a lot of them will have had prior cardiac surgeries. I think in those patients, the risk of surgery is not trivial. And that's when the heart team discussion really needs to happen as to what is how are we going to treat these patients. The heart failure cardiologist is an equally important part of this, if not the most important. Sometimes, we optimize them and, their TR is actually not that bad and we just follow them along. But I think the heart team for tricuspid, for the right-sided disease is even more important, I think, than it is for left-sided or aortic valve disease, for instance, in making the right decision.
Any other
Brian?
questions?
Yeah, Sachin, thank you. I think that, to me, as a heart failure cardiologist, when I see these patients, the biggest struggle is selection of this patient, what to tell a patient, and it just goes with everything. Is age, their symptoms, RV failure, how to assess the RV failure. From the LVAD data for years and years, we've been struggling to identify who's going to get RV failure after LVAD. So those are like the biggest struggle. And the LVAD data actually, we over years we developed all these scores, Euromax score and all those things that really help us to identify these patients, which one is going to have RV failure after intervention. Are there any things that's coming in the pipeline as far as the better assessment of RV and a score to kind of look at the whole patient, just not on one aspect of the patient?
There are some scores. That's a great question, Ryan. There are some scores that are in development or have been developed. There's something called TriValve score. It's not as refined as perhaps the LVAD scores are or your databases are, because this is so new. These therapies are new in contrast to LVADs and transplant, which has obviously been going on for decades. So yes, there are some scores that are being looked at in terms of identifying patients that are at increased risk of mortality early on. But I think we need to drill down a little bit more on this RV failure, which is not easy to predict, I think. A lot of the patients with RV dysfunction were excluded from these trials. But as you know, once therapies go from trials to real world, the patient population that gets treated always expands. So we need to be very, very careful when evaluating these patients, and we'll need help of heart failure cardiologists like yourself, who may be more, experienced in managing right-sided heart failure than us interventionalists or other cardiologists may be.
All right. Well, Dr. Goel, that was amazing. If I could finish maybe with a few things that you've alluded to on the questions game. One is, this is a serious disease. Two is, the vast majority is from secondary causes, right? So to Khurram Nasser's point, I feel that we could be much more aggressive in prevention. And the specialty of pulmonary hypertension and treatment of pulmonary hypertension, be it primary or secondary, is going to get us, to try to prevent some of this, because it can be too late down the line. Our assessment of TR severity is fine, but our assessment of RV function is really very preliminary at this stage of the game. If you ask me, TAPSE is probably the worst, for you to assess RV function. It is too late. Even RVEF may not be as good because the septal motion is very different, actually helps the RV. And most often, RV strain of the free wall is conceivably there, but it has to be put together, similar to what the Dr. Shah mentioned, with how much severity there is. And lastly, from my point of view, if we wait for symptoms, and the symptoms of TR and RV dysfunction are very subjective and maybe minimal symptoms of just fatigue. So the objective criteria that are in the VARC document are going to be very important, because otherwise we're intervening too late, and that's what it's telling us. We're intervening too late, and the question is, where? So, for those of you who are in research in this area, this is probably a most fruitful area to define RV function, all the severities and everything else, and be more aggressive in pulmonary hypertension treatment. So thank you very much for a great presentation and great discussion.
Thank you very much. 24 hours.